Okay, it's recording.
Hi, everyone. Welcome back to our Caregiving Advocacy Conference. We're going to actually move into a workshop to talk to you about a dementia care pilot program we just finished. And I'm pleased to have my colleague and friend join us, Eric. He's going to start us off. He's going to introduce himself and then take us through what the pilot program was and includes, and then we'll answer your questions because I think you'll have some questions. Okay.
Well, thanks, Denise. Assuming everybody can see the PowerPoint. I don't know how you're doing questions. It sounds like we'll save questions for the end, but we have Trudy and Deb with us too. So I think feel free to jump in at any point if you have some clarifying points or want to sort of highlight some things. Want it more of a conversation than obviously a talk. So my name is Eric Jutkowitz. I come actually from a research background. My work on the research side of things has been evaluating, implementing, testing different interventions to support caregivers of people living with dementia. About almost a year and a half ago now, I had the opportunity to meet Denise just through a joint colleague of ours. And Denise and I have really spent the better part of the last year thinking through how we could collaborate together. And what we came up with was an approach to really translate the learnings from research into sort of the real world everyday practice. One of my major frustrations from my work has always been that our learnings from the research world rarely leave the walls of the university. And so this was an exciting opportunity to try to solve that problem and reach more people who could hopefully benefit from the work. So we'll talk about this in a minute. I think, Denise, you're up first to talk through just a case example to motivate the talk.
Yes, so here is one of our pilot program participants. So George cares for his wife, and they're both 92. The first session of our pilot program included an assessment that's called an everyday function scale. So George and I went through a scale to determine his wife's functional ability on an everyday basis. And from that result, we were able to determine what are the care challenges we want to resolve. In the pilot program, we enrolled individuals to receive 5 coaching sessions to resolve 3 care challenges. Okay, yeah, thank you, Eric. The first session included George and a daughter, and the second session, 2 daughters joined George, and in the fourth and subsequent sessions, it's been George, 3 daughters, and myself. And it's been an awesome experience to coach a family system. During our sessions, the first 4 sessions, we really focused more on family emergency planning. It actually was because of Gene Hackman's death that George was much more open to the idea of how do we stay safe in the home. And interestingly enough, because of the everyday function scale, we were able to determine what his wife was capable of. And the function scale for his wife indicated that she would not be able to respond to alarms. So that immediately alerted us that systems would have to be put in place if there was an emergency. If something happened to George, for instance, we knew his wife probably wouldn't be able to respond. During these first 4 sessions, as we were talking about the family emergency plan, every once in a while there was a conversation about showering. And George would say it was difficult to get his wife to shower. So it was in the back of my mind, but it wasn't the priority initially until the 5th session. And that's when George really started talking more about it. And we started including information for him about how to have his wife take a shower with his clear directions. He had been offering a shower to his wife, and guess what happened when he said, "What do you think about a shower today?" She would say, "No," and then he would think, "Oh no, it's not working." So instead, we started talking about giving clear direction. Come with me, step into the shower, here's a washcloth. And at the end of that fifth session, which is when we really started talking about it, I was able to follow up with a care plan, which was a Word document that included a link to specific suggestions that was generated specifically from his wife's everyday function scale. So the technology that I was using to develop these strategies that were tailored to his wife is what Eric has developed. At the end of this fifth session, when I asked George how ready was he to try another shower, he was just like, I just don't think so. And that's okay. What was interesting then is we met a week later during the sixth session. I was just asking for updates. How is it going with installing a camera, getting a camera inside the house? What are the other updates around a personal emergency response system? And so George was giving us the updates, and that was the first 30 minutes. And then he said, "Oh, I gave her a shower on Saturday." And we were so happy for him. And what was interesting is he buried the lead because really it was such a momentous experience that we kind of wish he would have started with that when we started the session, but it was okay. And he said he followed our instructions, which was not to ask questions, but to offer guidance. And he said, "I could hear your voices in my head as I was giving the shower." And what was really effective was I was able to articulate what it sounds like to give instructions and then send an email with it written out. So it's just another way to receive the information. And then when the opportunity presented itself on Saturday morning, he went with it. And I did ask what changed on Saturday morning that it seemed like the right opportunity. And it just was aligning. It was laundry day. There were a couple other things that were happening that just made it easy for him to do it. And it was helpful for a couple different reasons. Again, it's the conversation, and then it's the follow-up information with clear instructions about what to do that's connected directly to that individuals with dementia, their everyday function abilities. And that's the power of this pilot program that we created, was matching this coaching. So it was myself and 4 other certified caregiving consultants that provided the coaching sessions, plus the technology to really give clear guidance to family caregivers around what can they do based on a caree's functional level. Could I just share something that just happened with one of our other pilot program participants?
Of course.
I have been working with another client for just about 7 sessions, and I knew that we needed to do a little bit more about helping her care for her husband, but she wasn't quite ready. And in the 7th session, she said, "Well, how do I know what he needs more help with?" Just like with George, with this client, I had gone through the everyday function scale with her in the first session, and I knew we needed to do it again because she was getting more realistic about her husband's abilities. So when she asked the question, "Well, how do I know what he needs help with?" I said, "We can do the everyday function scale again. There's 4 different options around activities. We could pick one, see how he does based on your observation, and that will help guide you to pay attention to certain activities that we then know you can provide more help to him." She's very much around, she wants to maintain his independence. She doesn't want to step in and take away, but she also doesn't want him to flounder, to struggle. And that's what we're always trying to figure out. When's the right time to step in? And I just love that we have this tool, which is an everyday function scale that can help that family caregiver really understand, when do I step in? I don't know if we can see that. So, yeah.
So this was I don't know, you want to talk, this was like an example of the actual care plan that you shared with George, who we renamed as the ASA
Yep.
conference.
Yep. Yeah. So we presented this at the ASA conference. So I used ASA as just, I don't know why, but that's what came up to me. So this is what it looked like in terms of generating it from the database, which is Plans for Care, which is Eric's organization, which I then had sent to George. And what I was able to do was create a Word document and include in the Word document a link to this document. And you can see at the very top, there's the everyday function scale for his wife. And then there's a description of challenging behaviors with options that are strategies to use. What I love about this too is it can be so hard to constantly reorient yourself into what can my caree do today? Because we know what he or she could do 10 years ago, 20 years ago. And that's what we tend to remember. It's this adjustment to a disease progression. And this everyday function scale is just a reminder of what's the current reality, what's possible today. And that's really helpful.
So this is the top part of the everyday function, kind of just zoomed in.
Could we go
Sure.
back just for a minute?
Yeah, sure.
So at that, so if you could make that a little bigger, it's just the third bullet item. ASA will not notice or react to unsafe situations like a smoke detector alarm. That was what we looked at initially that really triggered this idea that we have to put a plan in place so everybody's safe.
They might already know a lot about you, Denise. I don't know if there's
Yes,
anything else
they do.
you
Dude,
want
they know a lot about me.
you want to
I don't think I
share.
can add anything. I think they'd love to know more about you, Eric.
Okay, yeah. And so as I mentioned, I'm a researcher by training. My work has always been involved in designing, testing, evaluating programs and supports for people with dementia and their caregivers. And again, my main frustration has been over my research career that we find these things are effective, and then it's just so hard to get them to leave the walls of the university. And so about 2.5 years ago, I co-founded an organization company called Plans for Care with 2 other researchers. And the idea of Plans for Care is to package the learnings from the university side of things, knowing what works and doesn't work, and put that in a software solution that is more easily scalable and accessible to all the different types of individuals who support caregivers and people with dementia, from social workers embedded in a primary care practice to individuals who work at AAAs, or in this case, certified caregiving consultants. And so the idea is really trying to improve the reach of the science for more people. I think we're all here for one reason or another, and it's really by this broader motivation that our current systems and supports long-term care broadly, and more specifically for people with dementia, is not working as well as it could be. And I think I know Denise, myself, the other certified caregiving consultants are, I think, motivated by the challenge and opportunity to make caregiving a easier experience and to really fill gaps in the system. We know for dementia care, for example, we have some of my work, some of others in the field, that the amount of caregiving people with dementia receive is substantially more than people without dementia. The significant challenges associated with dementia caregiving contribute to last estimates over 320 billion in dementia care costs. And again, I think the motivation behind our work is that by improving the caregiving experience, we can not only improve individuals' lives, caregivers' lives, but also have an impact on the health system and reduce some of this potentially unnecessary healthcare spending. So our solution to this challenge was Denise and I coming together from, I think, this shared goal, but with slightly different perspectives and approaches to solving this. And coming together to have, I think, what I'd like to think a multiplicative effect than just an additive effect on the caregiving experience. Denise, I don't know if you, I mean, people here might already know a lot about the certified caregiving consultant training. I don't know if you want to kind of touch on it again, just so folks have an idea of who the CCCs are in the pilot program and sort of the level of rigor and depth of their training.
You guys have met some of our CCCs today. And it's a program that I initially launched in 2016. And it really came from this idea that the lived experience is this fabulous foundation for a former family caregiver to become a coach and consultant through their own small business. So the program right now is 101 hours. And there are 6 planning sessions that you learn that you can deliver to clients. And you saw one of the wheels earlier. So there's at least 60, I think there's probably closer to 80 wheels that I've developed. And there are concepts that we talked about yesterday that are part of the training program, like the 19 caregiving systems, the stages, and I mentioned the fatigues earlier this morning. The goal is that when a CCC completes the training, they have this really unique expertise in the personal caregiving experience and are equipped to provide services to support and serve family caregivers.
And so what we did was we gave the CCCs access to the Plans for Care database. Plans for Care database program included 4 hours of training on top of, this is sort of training on top of the regular CCC training. It talks about the sort of intuition behind the tool, the science backing the tool, and how to sort of apply and use the tool in practice. One thing that we did as a group was create a community, we're calling it community of practice, but it really was an opportunity for the CCCs to come together, as well as myself and some of the folks from our team. And we used it, we did it on a weekly basis, actually, and we used it as an opportunity to talk about challenging cases that may have popped up, unique situations, and really brainstormed with the full group potential solutions. And so an example of one of the calls that comes to mind, I think, was a caregiver was having a challenge with how to communicate to, I think it was like either the nursing home or assisted living community staff, that they were not happy with sort of how care was being carried out, and they wanted their person with dementia to be engaged in more meaningful activities. And so we kind of sat around as a team and I think presented a number of reasonable strategies for this for the CCC to deliver to the caregiver, but we also walked them through how to identify that challenge in the Plans for Care database and build out a care plan to address that specific challenge. So that's just one example of sort of many of the sort of conversations we had during these community of practice meetings. The Plans for Care software tool comes with several things in the box, if you will. Denise talked about the everyday function scale. It differentiates between 8 different levels of everyday functioning, from really the early stages of cognitive impairment, dementia, where somebody can be living alone and might need just a caregiver to check in on them maybe once a week, all the way to the end stage of dementia, where they require 24/7 support, can't really sit up on their own, and then everywhere in between. And, you know, it's the sort of in-between spots that are really hard to sort of identify, but the tool itself helps you get to that point and provide a description of what it means to be at one of those stages in between. We're right now working on a validation or crosswalk between the FAST, which is a tool that's used in some clinical practices to stage or determine dementia, a person with dementia's abilities, to the everyday function scale. The other aspect of the Plans for Care database is the list of more than 80 common caregiver challenges. So we have all the behavioral symptoms, agitation, aggression, wandering, challenges around performing ADLs, IADLs, challenges around, we call them caregiver-centered concerns, how to find time for yourself as a caregiver, how to help delegate responsibilities as a caregiver to maybe other family members or people in your care network, how to communicate with healthcare providers. So we have more than 80 common care challenges. All of this comes from our historical research, and these are things that have come up in our studies that caregivers say are their sort of concerns. And then the last part of Plans for Care is this database of more than 2,000 non-drug strategies. And what's really important is that each of these strategies are tied to a given level of everyday functioning, and they're also tied to a specific care challenge. So it's not like all 2,000 challenges or strategies work for one person, but we draw on this universe of strategies to really pinpoint and identify what would be most applicable for this person, given their everyday functioning and the care challenge. The database library is then used by sort of the certified caregiving consultants in this use case to build out the care plans, action plans. So
Could I
Denise and I,
mention, could I
yeah,
mention
please.
something really quick?
Yeah.
I had a client that said specifically, I do not want a medication as a solution. And I thought that was so helpful to say, of course, we'll figure something else out. And I should have mentioned this too, that we provided these coaching sessions at no cost to family caregivers. And I think it speaks to the commitment of the CCCs who really wanted to create solutions that worked by joining us every week to talk about the clients they were working with to ensure that they were really providing the best strategies to really support that family caregiver.
Yeah, awesome. So we merged the technology piece with the live peer support piece, which is the CCCs. We bring them together to provide the pilot program. And what's really valuable is sort of the human-to-human peer support interaction. You can't replace that. But those individuals are then backed by a validated and systematic practice through the Plans for Care software. We structured the organization of the pilot really around this idea of 5 structured sessions with the goal of resolving anywhere from 1 to 3 care challenges, depending on sort of what that caregiver was facing. For some caregivers, they may have only wanted to address 1 care challenge. For others, they could have actually done, I think, more than 3. But on average, the goal was to resolve around 3 care challenges over the course of 5 sessions. The sort of foundation of the encounters was all built around doing the initial everyday function scale to really better understand the caree's abilities. And Denise shared really powerful examples of how just the information in the everyday functional scale, when delivered to a caregiver, can lead to important discussion points around safety, reframing ability, and focusing on really a strength-based, I think, approach to supporting the person with dementia.
We have a question in the chat.
Oh, yeah, sure, go ahead.
Yeah, so Ken is wondering, is there crossover for use of these tools with other neurodevelopmental disorders, such as autism?
Yeah, okay, yeah, good question. We get asked a lot about crossover of other neurodevelopment disorders. The tool itself, the everyday function scale, is really good at differentiating how your cognitive abilities impact your ability to carry out everyday tasks. So I think it depends in part on what the specific diseases we're talking about. We haven't validated in other diseases, but Parkinson's is an example that we get asked a lot. And what the tool would be good at is identifying sort of the cognitive issues of how Parkinson's affects your everyday functioning, but it's not intended to figure out how the physical limitations of the Parkinson's is affecting your everyday ability. So there's an important distinction there. If you have tremors and it's because of the tremors that you can't carry out the activities that we're talking about. That's a different concept than what's being measured in the tool itself. The everyday function would be able to sort of use for Parkinson's case where it's like a Parkinson's dementia, so the memory, the cognitive impairments that are driving the limitations in ability. So I don't, I'd have to talk to our clinical team about the autism case. I know less about autism and how that interplays with some of these things, but I think with that general framework of how the what the tool is doing, that hopefully gets an answer to you at least initially, and I can follow up with after I talk to the clinical team about that.
And Ken is that close to being a certified caregiving consultant, like that close.
Oh, wow. Okay.
And so yeah, we'll keep in touch with you, Ken, about that, because I've wondered that too.
Yeah. So the pilot, we also did a few things around data collection, so we could measure, what we were doing and the impact of what we were doing on different sort of measures, outcomes, whether they be process or actual outcome measures. And so when somebody signed up to participate in the pilot, a caregiver, they went through a series of questions. It asked them, and you'll see, we'll go through these results. It asked them about their stress, their carees stress, their quality of life, their carees quality of life, whole series of questions. And then we actually asked this after they completed their 5th session, and we'll compare the results before and after. That was a unique feature of the program. In the 5 sessions, the goal was not only to address the care challenges, but to make fine-tune adjustments to the care plan. So these were not sort of documents that were set in stone. The intent is to work on the document, work on the care plan, refine them, and figure out what works in that specific situation for that client, caregiver, person with dementia environment. So to implement the joint solution, Denise recruited 5 CCCs. We have Trudy with us, Deb, Kim, Denise. I don't know if Andrew's here.
And Anne Marie.
And Anne Marie, yeah, of course.
Yeah.
We provided 4 hours of training to the CCCs in the use of plans for care. We did this over 2 days, over 2 weeks. So just training and sort of the intuition behind the tool, the research backing it, and then the actual applied use of the tool. As a group, folks completed test cases or sample cases just to get comfortable with the tool. And then I think, again, really powerful, and want to reiterate this, we had weekly team meetings to debrief, talk about challenging cases, discuss any issues that emerged, talked about things that were going well, so on and so forth. We did the pre and post program assessments. And then what was, I think, really valuable for everybody was we actually Denise hosted a session for caregiver participants to all come together. We did it on a Saturday morning, like 10 o'clock on a Saturday morning. And we had about, say, a quarter of the caregiver participants came. Most of the CCCs were there. I was there. A few other people from my team were there. We just had a conversation about the program, what they liked, opportunities for improvement. But I think it was nice because everybody kind of got to see each other, and it created a nice sense of community. Denise, is there anything you want to add about how we implemented the solution?
One of the things we included in the training was not only just practicing using plans for care, but we also created a session flow to help that CCC integrate the technology into coaching sessions, meaning that this was something new for us to do. So the guidance was have a coaching session, use plans for care between coaching sessions to develop strategies and care plans, and then follow up at the next session. So we created session flows. We had a little cheat sheet that you could use to take notes so that when you completed a session recap, which became really important, you had notes that you could then turn into a session recap. And I think you'll be interested when we talk about what the coaching sessions were like. That data will be interesting to you.
So this one of the things that initially stuck out to me was how quickly Denise and the CCCs were able to find and enroll caregiver participants. From the research side of things, it can take months to enroll people in studies. Our goal in this project, which wasn't a research study in any way, but an actual implementation of a program, our goal was to enroll 25 caregivers. And we did this in 4 weeks. And I think it really speaks to, again, like the CCCs, Denise's reach and reach within the community. Do you want to talk, Denise, about the recruitment approaches? Because I think you used a couple of them and they were all really successful.
One thing we did was host 2 meetings that anyone who was interested in participating could join to learn more about the pilot program. And a couple of the CCCs joined me, and we did just a real quick overview. This is the pilot program. This is what you'll receive. This is what we'd love to learn from you because of your participation. What was interesting is during those meetings, a couple family caregivers said, I'm overwhelmed. I don't know what to do. And I would say, that's a care challenge. We want to help you with that. And they were thinking, I'm so overwhelmed, I can't participate. And we really presented it as, that's why you participate, because we want to help you with your overwhelm. I had a family caregiver connect with me on LinkedIn because of one of my posts, one of my thought leadership posts. He had sent me an email in January. We connected on January 24th, and I told him about the pilot program. He said, sure, I'll join. And I had created a way for people to join on the 25th. And before I could even tell him, he had joined. So before I publicly announced we had someone who had enrolled, I think it's most important to think about establishing relationships. That's what really drove enrollment. There were a couple participants that were a little hesitant. One in particular, she just couldn't imagine that there was something she could talk about. And so I met with her in a chat, our chat room on Caring Our Way. It was just her and I. And she was telling me about what her life was like. And I said, I think it would be great for you to enroll in the pilot program. And she said, but what would I talk about? And I said, you just told me 3 care challenges. And I listed them for her. And she said, oh, I could talk about that. And I said, yes, you can talk about that. I think it really also speaks to how we have to perhaps change a little perspective of a family caregiver thinking, I don't have anything to talk about. That was that perspective. And the other thing is, I have too much to talk about, so I can't even imagine what this program would do for me. And in essence, it helped in both situations, overwhelmed and, I'm not sure I have anything to talk about. Because honestly, this client who said, I'm just not sure I have challenges to talk about, we still talk. And every time I meet with her, there's a new challenge to talk about. And I just reiterate to her, this is a new challenge we can work on. Really, we could work on this. And I would always say, yes, I would love to work on this with you. So it does take some hand holding. And that's a good thing because it's the relationship that matters. It's the relationship that I think really makes the difference.
Yeah, that's going to be one of the I think that was one of the key themes and learnings from this is really the value of the human interaction relationship and how the software that is there to support that, but it's not there to replace it. And so I think that's really important to keep in mind. So 25 caregivers completed the pre-program assessment. We had a few caregivers who dropped out before the first session with a CCC for a couple of different reasons. One was 1 or 2 were because of a death in the family of the person with dementia, and a few others just didn't schedule their first session for whatever reason. As of 4/16, these numbers are actually a little higher now, but 4/16, when we had put these slides together for presentation at ASA, 15 caregivers completed a pre and post assessment. I think right now we're actually at 16 or 17. So those numbers have gone up. And really powerful to me was the fact that close to 20% of the 15, 3 of the 15 people continued beyond the 5th session. So they continued working with the CCC. They're getting a lot of value from that relationship.
I think that number has gone up too.
Oh, okay. Yeah. Really deep engagement with folks, so wouldn't be surprised. So we have Trudy, Debs, Kim is with us on the call today. They're also on the slides. The other CCCs, Andrew, Anne-Marie, and Denise, which again, we forgot to put you on here, but
I forgot to put myself on there.
You want to tell them about the badge?
Yeah, so after they completed the program, which included the post assessment, plus their 5 sessions to resolve 3 care challenges, they were issued a badge. And the badge is part of their profile on Caring Our Way, which is our community. And it also can be added to their LinkedIn profiles. So the badge has the ability to be shared on social media. We really wanted to highlight their participation in a program that can help other family caregivers. And honestly, because of their participation, we have a program that can help other family caregivers. It really was that important to test this out with this group.
Yeah. So we collected a number of different pieces of information. After every session, the CCCs recorded the length of the session, and we'll share some data on engagement times. During the sessions, CCCs either asked the client questions around how difficult does the challenge feel to them, how upsetting is the challenge, how confident do you feel in managing the challenge, how ready are you to implement, or based on their conversation, they were able to infer this and answer these questions after the fact. These specific questions are scored from 1 to 5, and you'll see some of the data on that as well. And then we also had the CCCs record the caregiving systems, 19 of them, right?
Yep.
So and you'll see all the different caregiving systems that were mentioned during the conversations. Before the first session, after the 5th session, we also asked caregivers to record using a structured sort of survey tool, how stressed they are, how stressed they think their caree is. To answer the question, I need a listener in my life with whom I can talk honestly about my caregiving experience. And then an instrument that's called the Perceived Change Index. It has 13 items. Basically, the questions in this sort of instrument get around the caregiver's ability to cope and anticipate the needs of a person with dementia, as well as to provide care for the person with dementia. And then we asked quality of life questions about the person with dementia and quality of life about the caregiver. There's 12 items in each of these sort of measures, and what we do is we sort of average up across the 12 and we'll report the averages. We also got really great qualitative feedback, not only through the listening session we had on the Saturday morning, but as part of the post-program assessment, caregivers had an opportunity to write in their thoughts as well as answer some of the more structured quantitative questions or structured surveys.
Something that was really important to me about the pilot program was we asked for the family caregivers to give us feedback on all aspects, which included what was it like to go through the pre-program assessment. If you've ever gone through an assessment in order to have programs and services available for your caree or even yourself, you know that sometimes these assessments are really just an awful experience. And so what we tried to do was create a different experience. And then I asked how family caregivers felt about that. That was important to me. And so we were able to collect information about their experience with our pilot program throughout Every interaction that they had with us, they were able to give us feedback, which only goes to improve what program we offer family caregivers.
Yeah. So we had 20, this is for the 25 that at least completed the initial pre-assessment. We had 25 caregivers representing 23 carees. So some caregivers, some carees had multiple caregivers participating, which was really interesting and nice. Carees on average 70 years of age, and about half were males. Caregiver demographics, on average 59 years of age, 84% were females, 76% were white, the rest non-white. So those were the demographics. When these numbers were reported out, we had completed 67 sessions. Since then, we've now completed 98 sessions, so the numbers have gone up. I anticipate the results would look very similar. On average, a session was close to an hour in time, but you can see there was some variation in what session length looked like, with a few sessions being a little longer at the 100-minute mark, and a few being a little shorter at the 30-minute mark. But on average, across all 67 sessions, about an hour. Again, we've now completed 98 sessions, and a total of 81 hours of sessions. So really pretty amazing.
Yeah,
So this is
within 3.5 months,
within
amongst
3.5.
just 5
Yeah.
people. Yeah, 5
Yeah.
coaches.
Yeah, which is amazing. So this is data across all the sessions. This is data on the length of engagement per session. So this is, among everybody who completed a first session, this is on average how long that was. And among people who completed a 5th session, this was how long on average they spent. And it's actually fairly consistent. So I think that's nice to see that, like, not all the time is being spent either up front or at the end, but it's really being evenly, uniformly delivered across the sessions. And to me, signals really the fact that there was powerful, deep engagement happening, and it was consistent. So people were getting value of this over time, and they kept investing in it. Denise talked just a moment ago about, like, the duration of time. What was also interesting to me was that for the 15 completers, when this data was run for the presentation on 4/6, the time from the 1st to 5th session, 30 days, 1 month. So really a rapid period of time. And it's going to be important to just keep this in the back of your mind when we go through the results. Think about the impact that's happening in, again, I feel like a pretty short period of time, 1 month. So really important. On average, the time between the 1st and 2nd session, close to a week. 2nd to 3rd session, about 10 days. 3rd to 4th, about 7 days. 4th to 5th, about 7 days. And what was interesting, and Deb, I don't know if you want to comment on this at all, but when we shared the data with Deb and the other CCCs, said that makes sense that the 2nd to 3rd session is longer, because I purposely scheduled out those times further out in advance so that the caregivers had time to sort of internalize and then practice the action plans.
I was very deliberate about not trying to do it a week later, giving them extra time for that very reason, because the first time you get our notes and the first time you see the strategies from the care plan, it takes a while to absorb it. It really does. And so I wanted to give them enough time, and offered, if you have any questions, don't hesitate to call or to reach out. And, everybody by the 3rd session said, yeah, I had a chance to try this, and it did or didn't work for that reason. And they didn't, we focus on one care challenge, but there's a lot of different things you can do. So there was a lot of trial and error, but that's what it is in dementia, what works or doesn't work, and what works today and then doesn't work tomorrow. So, but yeah, it was helpful, I think, for them to have some extra time.
Cool, thanks. Yeah. And it's always nice when you see something in the data and there's a good explanation for it, because so often I work with data and we see these things and there's nobody ever to ask and really understand what's going on. So that's a fun thing to see. So this is the district. Oh, go ahead, Trudy.
I was just going to say, I agree with Deb, because just providing specifics to some of the folks was important. You can say, oh, you're very stressed. Well, you need to give more time to yourself. So that's pretty broad, but we were giving some specific things for them to try. So we did have to allow a little bit more, kind of a lead time before checking in again with them. So I agree.
Cool. Yeah, thank you. This was the distribution of the everyday function scale among everybody who completed one. On the far right, what we call G, just called something shorthand. G, this is the sort of most advanced, most dependent, furthest along in sort of the dementia stages. A1 would be the very early stages of memory impairment. And it's actually kind of a normal-ish shaped distribution, slightly skewed towards sort of the right side, meaning more dependence. I won't go through all the different levels, but I'll just kind of pick out a few of them to give you a flavor of what this means in terms of ability. So again, G, this is end stages of dementia. Somebody cannot be alone, requires complete assistance with daily activities. They need 24-hour total care. They need help to kind of sit for short periods of time. So as we go from right to left, we're sort of improving in level of ability or function. Level D, which was been the most common one, based on what you shared, Leo, who in this example is the person with dementia, needs 24-hour oversight and can be alone in a room for less than an hour if somebody is nearby. They'll not notice or react to unsafe situations like a smoke detector alarm. So again, really powerful in terms of the safety piece there that can guide a conversation.
I just want to add something, and then we have another question in the chat room. When the client receives the everyday function scale, they actually can move from where their caree is to what's next. I found that really helpful. So there's guidance as to what could be the next stage on the function scale. So it's not just receiving where it is right now, it's where it could go. And so Ken has a question, and his question is, was there a full evaluation done for dementia as part of the research?
So we do the everyday function, with the CCCs, I should say, do the everyday function. And this is really the backbone of what guides conversations and what informs the action plans. We don't get into, and for the purposes of, I think, the work that we're doing, we don't get into anything about what the specific type of dementia somebody has. Now, they might know that from their doctor and might share that information, but for most of the strategies and action plans, the type of dementia actually doesn't matter. This is kind of agnostic to that, and so I don't know if that's what you meant by full evaluation, but this is not this is not a clinical evaluation. It's not a doctor's visit. Yeah.
And we were really careful about that. As caregiving consultants, we actually do not in any way provide a clinical analysis, a diagnosis. So we really use this as helpful information to understand a caree's functional level in order to determine what strategies could help.
Yeah. And then just to give you a feel, like as we go across sort of the spectrum. This is A1, because it's not enough space to actually give the full description under these things. This is the very early stages of dementia. So somebody has a high level of ability to do different activities. Based on what you shared, Leo can live independently. He'll reach out for help if needed, but it'd be beneficial if someone visits the home every other week to make sure everything is okay. Again, everything in between. There were 144 care challenges that were selected over the course of the pilot. 44 of these were unique. And what we have here are the top 10 care challenges that were selected. 5 of the top 10 care challenges were related to some sort of dementia-related behavior. So hallucinations, delusions was the most commonly selected care challenge. There's restlessness of the person with dementia, repetitive questioning, agitation, anxiety, worry, and fear. So really like the dementia related behaviors. The other care challenges that were in the top 10 were a lot about, I kind of call them caregiver-centered concerns. So feeling stressed or overwhelmed, finding time for yourself, structuring time for yourself, communicating with healthcare providers. It just gives you kind of a feel for what the challenges people are selecting. Now, again, somebody over the course of 5 sessions might only work on 1 challenge. They could work on more than 5. On average, the idea was somebody would work on 3 over the course of those sessions. The caregiving systems. So these were documented by the CCCs after each session. Family was the most commonly mentioned caregiving system, followed by relationship, medical. At the bottom, narcissism, education. Denise, any points you want to raise about the caregiving systems?
We went through the whole presentation yesterday. So everybody is an
Okay.
expert in the 19 caregiving systems.
Yeah.
Although I just want to add that it's really cool to see it in terms of documented what
Yeah.
it's like in the reality of a family caregiving situation.
Okay. This was for the 67 sessions again. We now have 98 complete. So I think the numbers will be pretty stable from what we're seeing here. Again, after each session, CCCs reported how did the session go? How difficult does this challenge feel to your client? How upsetting does it feel? How confident does your client feel? And how ready? And what we did was we looked from the first to last session, and we were just interested in how these reports were changing. Each question was scored from 1 to 5. 5 is like better. 1 is sort of worse on these items. So how did the session go? 3% improvement from first to last session. How difficult does this challenge feel for your client? And actually, people were saying it felt more difficult over time, but when reporting how upsetting and how confident you were, they increased by close to 10%. And the biggest increase was how ready was your client to implement this strategy, from a 3.7 on average to 4.6, 25% improvement. So really working with peer support, the CCCs made caregivers feel ready and confident to implement strategies that could have a positive impact. We also did the structured surveys before participation in the first session, and then after participation in the 5th session. Here, 5, each item scored from 1 to 5. How stressed are you? 5 is very stressed. 1 is sort of not stressed at all. Stress decreased. So positive improvement. How stressed do you think your caree is? An improvement, a reduction in stress. Perceived change, again, measure of number of questions around sort of ability to cope, ability to anticipate and implement change. it increased 1.11 points. So a positive increased. 5 means improved a lot. 1 means got him worse. Quality of life of the person with dementia, an improvement from before to after. And quality of life of the caregiver, also an improvement from before to after. So all the sort of numbers are moving in sort of positive directions, which corresponds also with sort of the testimonials and qualitative statements that were shared through the sessions. So one of the last pieces of information that we collected was asking caregivers, how satisfied were you with the program? 1 to 5, 5 is sort of the highest, extremely satisfied, 4.7. And then we had a list of sort of statements. For example, I feel my caree is less stressed. We had a list of statements, and we asked caregivers to endorse those statements which they felt applied to them. And these were the most commonly endorsed statements by caregivers. I feel my caree is less stressed. I feel less stressed. Again, these statements are now matching what we're seeing with the quantitative data just before this. I feel relief because I connected with a good listener. I feel more confident in my ability to provide care. I have care plans that help me. Again, another comment about the value of a good listener, and I resolved my 3 care challenges. Okay, so that's impact in terms of numbers, but I think impact in terms of actual case examples is just as powerful. Denise, do you want to share?
I think I'll actually have Deb share because this is her client. And Deb, just as an aside, I couldn't get the video to load into the PowerPoint, so I just took a screenshot. So that's why it's just a screenshot.
That's okay. Yeah, yeah. This still makes my heart sing when I look at it. So I had the opportunity to work separately with a husband and wife, which I found really fascinating. And I kind of did that deliberately to see it's his wife's mother who is living with them with dementia. So they had different stressors, they had different interpretations of her mom and a lot of things. Anyway, the long and short of it is, in working with the husband, we were talking about some strategies because she could get agitated, and actually the hallucinations were really, really bad. And I said, well, what about music? And his response was, my wife doesn't think it's going to work. She, no. I said, all right, if it comes up, let me talk to her. So it came up. We talked about it. She said, all right, we'll try it. That is the same day that they put the headphones on his mother-in-law, and that is she and her daughter dancing to Hava Nagila, which I just love. And that, I think some of the statistics, we were talking about, people in their head are thinking, A, it's not going to work, or B, I don't even know how to make it happen, So I think it's important that she allowed it to happen, and it turned out to be wonderful. There was another short video with her mom sitting on the couch singing. But what was really the part that was great about that was she was actually in the living room. Normally she would have isolated in her bedroom. So that was really wonderful to see her kind of out and being with them. But yeah, it's really cool to see them dancing to Hava Nagila.
So what were our insights, and what did we learn? The caregivers who participated in this program, we kind of described as well-connected. They were, they had connected with other resources in the community, yet they still had unmet needs. And so this program was helping to fill those unmet needs. And again, among a group of well-connected caregivers, and it makes us think, for those who are not as well connected, the unmet need can be even greater. The second key insight, and we've kind of touched on this a lot, was the value of peer support and the relationships from the CCCs. And you just can't replace that, but you can support it through software and tools. Consistency in relationship was important. So we found that having the same CCC working with a caregiver over time, I think improved trust. It improved the quality of the relationship. Often we hear from caregivers that they have to kind of repeat their stories over and over again. Just can be frustrating. Not how people want to spend their time. And so having like a consistent relationship was really powerful. And then the last key insight for me was that, again, over a really, I think, short period of time, a month, we had meaningful outcomes. And so it's possible to have positive benefits in short periods of time through peer navigators. Denise, what were your takeaways, insights?
Yeah, I do think it was so interesting that we connected with family caregivers that were already connected to resources and support, and that this was something that still was helpful. And this idea that they could select their consultant. So there was a page where all of us were listed. They could select who they worked with. They weren't assigned, which I think is so important too. So there was choice throughout this experience for the family caregiver. They chose their consultant. They chose the schedule. They chose the care challenge. They chose which strategy would work for them. And then we can see what happens when there's that much choice within that kind of support system. It's really powerful. And what I think is so interesting was there are a couple fifth sessions that I had with clients where I was just like, what an amazing fifth session. And the other thing that we did was we gave the family caregivers a lot of room to resist. I'm not ready to do this. This isn't the right solution. We gave them all the room they needed to resist. And once we gave them all that room and they got the resistance out, they were ready to try something. It really was amazing. I also want to mention the other thing about the everyday function scale. When we talk about it, we talk about it as a matter of fact. Oh, matter of fact, here's what your caree can do on an everyday function scale. That's an emotional experience, though, for a family caregiver to go to have this really fact-based assessment of their caree's functional ability. That's hard to hear sometimes and hard to process. And so to be able to go through that with someone who understands and who's kind and compassionate about that, I think is also really helpful and makes it a little bit easier to receive how a caree is doing.
Yeah, awesome. So what is the future of this program? We have two things in the works. One is embedding the plans for care database, everyday function, action plans as part of as an available option for CCCs. So folks who are going through that training or who want to go through that training and then use the plans for care database, that's something that's immediately available. And then June 1st, we are launching a platform that will connect caregivers with individuals who have a demonstrated competency in supporting caregivers. So we're going to link caregivers with CCCs or licensed individuals who have, again, some sort of demonstrated competency, expertise in working with caregivers, and we're just going to help link them. We are also going to provide the CCCs or the licensed individuals access to the plans for care database as part of participating in that linking process. We're going to launch June 1st. And the idea is to kind of scale the model that we just tested so that more caregivers have access to support.
And I think it's actually June 16th.
Oh, yeah, we just changed, yeah.
Yeah, we changed it.
16th.
We had very high aspirations of what we could accomplish throughout the month of May.
Did you want to comment on anything else about the future?
Just one other thing, we have approval for family caregivers who are working that have a benefit that allows them to spend FSA, HSA dollars on different products and services. Working family caregivers with that benefit can spend their FSA, HSA dollars on a consultant or a professional listening artist, or either one of those. So in that direct to consumer solution where they can pick a consultant they want to work with, they can use their FSA dollars to spend on a coaching package. And we'll probably do something very similar where it's 5 sessions to resolve 3 care challenges with the additional opportunity to continue working with a consultant if a client would like to. Oops. Okay, so what do you guys think? What questions do you have? And as you guys are thinking of questions, we'd love to hear from Trudy, Deb, and Kim. What was it like for you to go through this pilot program?
So I'll start.
Yes.
Trudy, yes. It was an amazing experience. I really felt so honored to just hear and talk to other family caregivers, because my story again is very similar, but I had no one to talk to. And the one example that I'll bring up, we spent the first hour even longer, and it was so emotional for both of us because I was just listening, and she had a very emotional experience because no one really had supported her at all just by listening. So we took it slow, but then again, we started brainstorming on what her actual issue, or, she just had so many challenges. She didn't know where to start. So we actually did that together. And she felt very, as her husband's advocate, he was really on the everyday function scale, was at the very low end of the scale. We'll just say that. But he was in a long-term care facility, and she was his advocate. He could not talk for himself. He had no one to just say, this is, how it is. This is where they needed help. So she became his voice, and she didn't know where to start or what she was even capable of. But I think over time, I saw that her courage really showed up in so many different ways. And it was really amazing to see. So part of that was just figuring out with the plans for care that Eric, you mentioned before. We kind of brainstormed that, but it was about a couple of things. And one was communicating with the healthcare personnel, the staff, the environment, and how to do that effectively, how to feel that she had a good strategy for doing that, and then creating that plan together. That was important. And then the follow-up, it kind of happened not the way she had anticipated, making her appointments and doing, getting that care plan update. She happened to run into the director in the parking lot. And she even said at the time that she wouldn't have been able to matter-of-factly say, this is what my concerns are, but she caught her in, at that point, and felt really empowered to just say what she was thinking and have an action plan. So all these things just came together. And I do think over time that, we worked on several other things, and she just found different strategies from the plans for care. I was able to pull a couple, like I said, it was not just one, but I felt that at the time there were several that we pulled together that was helpful for her advocacy.
Deb, would you like to go next? And then we'll move to Kim.
Sure.
Yes.
It was great. It was a great experience. I appreciate very much when we had input during the process. Eric was open to it and made changes on the fly for us, which was terrific. You know, so that part was very, very smooth. And and just from a technology standpoint, it's easy to use. You know, the first time or two, you're like, where am I going? What am I doing? But once you get it down, it's easy to use. And one of the things I appreciated was dementia is often very complex. So, you know, hallucinations, delusions are oftentimes coupled with repetitive questioning. So the ability to go in and actually create one care plan that looked at both of those and then be able to pick the strategies, you know, some were, you know, that made sense, and then say, okay, you know, they're in the hallucination, you're getting the repetitive questions, right? Here's how you can kind of stop that kind of thing. I think the part that was most wonderful was it really became a partnership with the people that you were working with and helping, you know, because I might pick a strategy, and it's like, okay, what do you think of this? No, it's not going to work for this way. Okay, we can revisit that if we want to later. Like, I'm not going to try and push you into doing anything. Okay, you know your person better than I do. So if that doesn't work for them, that doesn't work for them. You know, it's the kind of thing like made a suggestion for repetitive questioning, and it's like she lost the piece of paper right away. How about a whiteboard, right? Like, you still want to use the strategy of having something written down so that you can say, oh, you know, it's on the whiteboard, go look at it, and give them a sense of ownership along with not driving you crazy. So it's really interesting sometimes, you know, you think, oh yeah, write down the answer, but the way in which we had to deliver that was not the same for everybody. I thought that was really kind of interesting. So it was a true partnership. And interestingly enough, one of the people that I worked with, she was so overwhelmed that the pre-assessment was something that she's just like, I just can't deal with this. So her son took it. And the very first meeting, it was she and her son. I think it was the very second meeting was she and her son as well. We just had our 7th meeting this morning, and her son is no longer part of this because she feels comfortable enough with me, and she feels comfortable enough with where we're headed that support system is no longer necessary. So I think that speaks a lot to, you know, how well this can work for people.
Kim, what would you add?
Gosh, I guess I would just have to echo what Trudy and Deb said as far as I really enjoyed the program. I felt that it was such an honor to even be a part of it. The mission I felt was just so important, as was shared in the presentation, and I think that we all feel that same way. As far as my experience, I have to say, you know, I don't want to say I was fortunate enough, because we want to help whoever we can help. I feel like just to be fully transparent, it was a busy time in my life, but I still wanted to be a part of the program. So for me, it worked out that my main caregiver that I was helping, I mean, she was on it. She had things in place, you know. It's like, even just talking to her, I'm like, gosh, I used to do that. That's great. Like, I would say definitely had everything under wraps. The beauty of using the tool was, and of course, by us having a conversation, kind of like Trudy, that first conversation actually went longer than we planned, just talking different things out. One of the care challenges we worked on, the first one was mobility. And, you know, again, like I said, she had a lot of things already kind of set up as far as she moved things that were easier for her partner. And but through the tool, a simple suggestion. It seems simple to us, but when I saw it, I was like, huh, I'm going to share this with her. And that was to make sure or to adjust lighting throughout the rooms. And so that way, because, you know, the shadows won't disorient him or anything like that. So I included that in the care plan, sent it to her. And then when we met, you know, we discussed it. And that was the one that she said, that was the best suggestion out of everything. I mean, she agreed with the other things I shared. But to be really honest, she was doing most of them. But the light, she was like, it's so simple, but I'm so glad that you suggested that, because she realized going from the living room to the hallway, there wasn't, I think there was lighting that he had to turn on by his chair or something like that. And long story short, she was like, oh my gosh, I didn't even realize, you know, he could fall in. And so we spent a lot of time just being so grateful for the tool and just being able to get suggestions like that. And I'm just really excited to see how this will help in our caregiving consulting community, but also just for those that are dealing with caring for those with dementia. And again, like as others have kind of mentioned, maybe how it will grow in the future to reach other demographics.
Something too that I have often talked about, which is that family caregivers will make time for what's helpful. And we could see that they made time for this, spending almost an hour every week or every 10 days with a session with their caregiving coach. They made time for it. And people often will say, family caregivers don't accept help and support. It drives me nuts when someone says that, because it's not true, because they are very intentional about who and how they accept help, because they've had lots of experiences using help that doesn't help. And this was help that helped, which was why they stayed consistent in the length of time they gave to a coaching call, because it was helpful. And it wasn't us telling them what they should do. It was us listening to them and then offering them suggestions that they then figured out whether or not would work for them. That was really the beauty of the partnership, which is what you guys have been talking about. What other questions might you guys have? I took some notes as we were talking. I want to make sure that I got
Denise,
everything.
I got a chat message today.
Okay, thanks, Beth.
You're welcome.
Eric, I'm curious, what did you, what expectations or goals did you have before the start of the program? And what was an outcome that you were particularly happy about?
I think I was a little unsure how the implementation of everything would go, from being able to recruit 25, just being able to sort of execute and carry out the whole program. I was unsure what hiccups would come along the way. And to me, it felt pretty smooth. So to me, that was very nice. I don't know if I guess it was a surprise to me. I thought we would have a harder time enrolling caregivers and finding them, just based from research experience. So I thought it went actually a lot smoother, the whole process, than I was expecting. The program itself, I think, reiterated some ideas that I had in my mind, but it was good to see sort of actually carried out, and the data and the experience reiterated. Again, that's the value of the human connection and being able to support and extend that through software, but not having software replace it. Because I feel like too much we hear just in everything in the news and whatnot, that software AI will replace, or software is going to replace people. I just think this really underscored the value of software as a tool to support, not replace. So that was a nice reinforcement learning. I think what I'm most excited about now, seeing how smooth we were able to carry this out, is the next stage and being able to connect caregivers with people who have demonstrated competency in supporting them. And that's, I really hope, what differentiates this matching platform that we're going to build out than what's currently available, where feels like a gap to me is one, it's really hard for caregivers to find, I think, adequate peer support and or sort of in the sort of traditional healthcare professional sense, people who can provide support to them. And so that to me seems like a huge gap and a huge opportunity to help with what we're going to do next. So I'm really excited about the next phase, about trying to match caregivers to people with a demonstrated level of competency, which I think is going to be really important.
Yeah, I'm really excited about that too, because there isn't anything like that. And one of the things that we've talked about as we build out this solution is to really think through, how do we offer enough options so a family caregiver really feels like they can connect to a peer that reflects their definition of a peer? Because we want choice to be a part of it. It can help if you feel like I'm already connecting with someone who has an understanding of the impact of the caregiving experience on me. And when someone else understands the impact, you already have a connection. So this idea that you have a choice about who you can work with in order to receive support is so powerful. Because think about how often we don't have a choice. We don't have a choice when we call a payer to talk out insurance coverage. We just talk to whoever it is that answers the phone. When we call a community-based program, for instance, they do everything they can to really provide an excellent experience, but it could be that funding cuts make it harder to have a full staff. So you might just connect with someone who only has 10 minutes because that's how overloaded they are because of funding cuts. So we really believe that this is a powerful solution at the right time that is a unique and innovative solution to support family caregivers. And there's nothing like the lived experience, and elevating that lived experience is huge. Yeah, thanks, Tiffany. So Tiffany's writing in the chat room, I love the choice that caregivers get to have. It's so powerful, which allows them to gain confidence in knowing that they are a wonderful advocate for their loved one. That's awesome. And one of the things that we talk about in the CCC training is you lose hope during a caregiving experience, and sometimes you lose hope for your own future. How much have I lost during caregiving? What will I have after caregiving ends? And when you work with someone who has transformed their personal caregiving experience into a coaching business, it's a different way of looking at what can I gain from this experience. Now, you may never do that. You might think that's so awesome, someone else wants to do that. That's not in my cards, but it's just this idea that you see possibilities still exist. It's not all lost. There are gains to be made. It really was an awesome experience. We did a lot of work in a short period of time, really. And we challenged ourselves to get that work done in a short period of time. We had hoped to be able to launch the program as a pilot in January. We had a few delays, which actually worked out fine. And so then when we launched it, we really were ready to launch it. And I learned a lot about how to launch a pilot program too. So Eric, you were my test case.
Yeah, you were my test case too, so. Maybe that's why it went so smoothly. We didn't have anything to like hold us back.
That's right. We had no idea what we were doing, so that worked in our favor. Okay. Any other questions? Oh, so Beth is wondering. Yes, yes, it'll be available in
You know
Canada
what
too.
time is tomorrow?
Yeah, Beth, I'll put it in the chat room for you. So
Thank
the question of making it global, so not just Canada, but global is excellent. And yes, that's possible because we have CCCs, for instance, who are based in Canada. We have CCCs in other parts of the world. So we can make this available wherever there is someone who needs it, and perhaps a peer support specialist, like a certified caregiving consultant in that area. We worked with Beth in the pilot program, who's from Canada. So we can work with anybody, regardless of where they live. And I think definitely we want to think about, yeah, we just need Zoom. And we want to make sure that, you know, the one thing that we have to look at is how do we make sure that the language is supported? We talked about this a little bit at ASA when we were delivering the workshop, thinking about translating into Spanish, because we have some Spanish speaking consultants. And we have a French speaking consultant, Cynthia, who was here earlier from Canada. So we'd love to support different languages as well. Okay. Oh,
This
go
is
ahead.
Deb.
Yeah,
I just want to
yeah.
make a quick, I think one of the things that's so interesting, like we know the value of this, but I have been pleasantly surprised by other people in this elder care space, including my gerontologist today. He was really excited about the program. Like, oh my gosh, this is so important for family caregivers. So I think it's really interesting that people are recognizing there's a gap for the family caregiver and that this is something that could really help.
And if you think about how time pressed staff in a physician office are, this would be a fabulous referral for them to make. People stop by the desk as they're leaving and they might say, you know what, so-and-so is happening. Do you have a referral for this? And the front office staff is thinking, oh my gosh, we've got so much else to do. And they can just refer to us. We've really been thinking through what does this look like in terms of Medicare Part B services that we know Medicare now reimburses for. So Eric and I have continued that conversation and really have thought about how does this fit into those kinds of reimbursable services. So we're just starting and there's lots of opportunities. Okay.
Well, I just wanted
Marla.
to jump in really quick, Denise, if that's
Yes,
okay.
go for it.
I just wanted to say, again, I've been a part of a few pilot programs or beta programs, and I have to say this was the most enjoyable process that I've been a part of. And so I definitely wanted to thank everyone who was involved. You know, even Eric, we would go to him with like questions and suggestions, and there was never, you were always very open and welcoming, Eric. And so I want to thank you for that. Of course, Denise, answering any random emails that I would send, but also my colleagues like Trudy, Deb. I didn't really get a chance to connect with Anne-Marie, but now my brain is blanking. But I feel like we all helped each other in one way or another. I know I came to the meetings like, sometimes. So I just really appreciate the process and wanted to say it really was a collaborative effort, and I'm appreciative.
Yeah, thanks. Yeah, I think value of community, not just between the caregivers and the CCCs, but amongst ourselves is important, and helped ultimately the caregivers because we were coming together on the back end, coming up with solutions that we could then, that you could all deliver individually to client caregivers. So I think the different levels of community is really important and something we'll want to kind of carry through to the next phase as we sort of launch the platform that's going to link caregivers to CCCs and others who have expertise in supporting caregivers. We're going to try on the back end to still have that sense of community. I don't know if we'll meet weekly, but like we'll try to meet pretty frequently. And Denise has, I mean, you have a whole wonderful system built out for caregivers to have a nice sense of community.
Yeah,
like message boards and whatnot. So I think that's really,
yeah,
it's like the
yeah.
one-on-one stuff is it's all like a package and can't really be separated out.
Yeah, that was really the other thing that was so clear to us, was how important it was for all of us to meet on a regular basis to talk out what was happening, how to support our clients, and how to support each other, which was really awesome. Okay, I think we're going to finish on time. So Eric, thank you so much.
Thank
Thanks for
you.
being here today. We so appreciate it. And we're going to take a 10-minute break, and then we'll come back